expect to live a healthy lives. We must take responsibility. It's unfortunate that as we evolve with our urbanization is upside is done. So, and communities and societies must take responsibility. Government will try, but ultimately we must put our faith in our hands. Now, governments on their own part must take deliberate environmental intervention measures. Deforestation. If you travel by air, if you are one of those who are privileged to travel by air, those states over the last 10 years, as some of us have been able to, not because we can afford it, but because partners pick up the bill. Let me just make that this disclaimer quickly. I've had the privilege of flying, and over the last 10 years, you look at the forest cover of Ondo State has gone down considerably. Initially, you could see the thick forest cover. It's no longer there. All the trees are gone. You can now see the mountain tops. You can see the pasture lands here and there. So, and we don't know, we must put the government on notice. There must be deliberate attempt to plant, trees to replace what we own. Ondo State was one of the largest producers of timber. We were exporting, but now we are nowhere. So we must do that because it's important to protecting our ecology. Now, town planning is an issue. If we continue to grow urban jungles, then outbreaks will be with us. Without a decent town planning, you cannot have waste management. People can cry all they like about our cities, Akure, out the city center, but there is no way. Waste cannot be evacuated in many of our towns because there is no access. There is no access roads. If cities are not planned, if there are no road network, where would the waste collectors pass? If we continue to wait for families to carry their waste on the basket and bring it to the road, this is what you get. But if towns are planned, there are link roads, there are network of roads, there are drainages, the roads are well done, then waste management is easy. We can live better, vectors can better be controlled. So we cannot excuse government. Then provision of basic amenities, water, very, very important. Now that everybody is digging their well, and you don't know, there's a joke in the environmental health that before you dig your well, you must know where your neighbor put his soak away. Many of us are just quietly drinking from the soak away of our neighbor. So it's better for you to peep over the fence, look at where the septic tank of your neighbor is, so that you don't dig your well and be drinking their shit. Sorry for my language. So we must note that most disease outbreaks are initiated outside of the health sector by these factors. The health, we have to manage it, but these are the things that predispose to it. Now, for the precipitating factors that I mentioned earlier, we must strengthen our routine immunization. Irrespective of what some people may tell you, those who know, they know that routine immunization is not as strong as it used to be. These days that most poor Nigerians cannot even afford to get a taxi or a motorbike to the clinic to get immunized. It's as bad as that. And we are having a lot of deliveries outside of the hospital. Our ski bath attendance has dropped, delivery has dropped. So routine immunization, and that's why we are seeing yellow fever, we are seeing measles, we are seeing all of these things. We are seeing TB. We are discovering TB during outreaches. This means that we are living on borrowed time. Then the wash is very important. Water and sanitation, we must work on them. Very, very key. And like I said earlier on, enforce town planning regulation and enhance disease surveillance. We are doing better at this, but we can do a lot much more. So how do we mitigate the perpetuating factor against the perpetuating factors? Because like I said, even when we do all the other things, outbreaks will occur. But when outbreaks occur, the health system must respond and respond quickly and robustly. So our emergency management systems must be very up and running. There must be prompt case detection and isolation and treatment. Again, we still have challenges with this. Many of our mortalities from Lassa fever are because the health workers do not identify these cases on time. They kept them too long and too late, and they put themselves at risk while doing that. And we must continue to educate the community so that when there's an outbreak, it should be a collaborative response, not just the health sector itself. We must mobilize the community to be able to do the right thing. Okay, because we are to look at mpox, so I just spare a thought for mpox. Many people know that I have bias about mpox because they say that when you have leprosy, you cannot be chasing tinea. So for me, mpox is a global issue, but in Nigeria, Lassa fever is a more serious issue. So the morbidity and mortality of mpox may be moderate, but one thing we must pay attention to with mpox is the danger of genetic mutation. The virus is too close to smallpox, and that is why the whole international health community is paying a close attention to it. We don't want an antigenic shift and the virus to become more virulent, especially when many of us above 40 years or below 40 years, those below 40 years, I'm no longer in that category, thank God, are at risk to smallpox, having not taken the vaccine. So, and this is why everybody is looking at mpox. We are also aware of the fact that some dangerous people somewhere will also be manipulating it for warfare purposes. They say all is fair in war. So we must detect the cases quickly, report it and manage it, and make sure that we keep the mpox outbreak under containment. It was scary when it started showing up in different parts of the world and with atypical presentation. So contacts should be appropriately tracked. I'm saying this because many of the health workers who see it may not pay attention to it because they feel, well, it's contagious, but it's not very serious. Yes, it can be serious, but we must manage it very well. We must report it. And an effort to provide immunization to at-risk communities must be intensified. We have not been able to do that in Nigeria because the vaccines are not readily available. But if and when it is necessary, I'm sure the federal government will do the needful. But one thing Nigeria is doing, and every country is doing, is making sure that every mpox that we see, whereas we take it, we collect the sample, we send it to all the advanced laboratory in the world for gene sequencing and surveillance to make sure that we are not incubating something that will become a threat to human society, human population. So as I begin to round up, this is Physicians Week. So what should NMA be doing at this time? And I must, at this time, pay homage to all our elders in the house and those who are going to soon be joining the Elders Club. Dr. Adedosu bowed out yesterday. We celebrate him. He's a fellow soldier in the fight against outbreaks, and we wish him a wonderful rest, if he will rest at all. So doctors will continue to be at the forefront of fight against disease outbreaks. If we don't do that, then the outbreak will ravage the human society. We have the skills, we have the knowledge, we have the training, and we must show up when that is needed. And all categories and cadres of doctors are important. All categories. Junior doctors, specialists, general practitioners, laboratory specialists, researchers, public health practitioners. All of us have a role to play. We must not see outbreak as a responsibility of some people just because they are infectious disease doctors or because they are public health specialists. Everybody must join rank. A chain is as strong as its weakest link. There must be no weak link in our chain. Now, while other health professionals are necessary, the role of doctors remains very critical. Public health without deep knowledge of medicine is like a story building without a foundation. And I must sound a note of warning. As a community physician, I thank God that our guest lecturer is also a community physician. We are scared because the public health has become an all-comers affair. All sorts of people. Very soon you will see Nollywood people getting masters in public health. Alawadas are coming to public health. It has become a house of jesters. And it has grave implications for the future. While everybody has a role in public health, doctors must stay at the heart of it. The heart of public health is epidemiology and biostatistics. And doctors must seize that initiative and lead. Because when people who do not have a background in health rise to the level where they write public health policy, there will be danger for us. So please, I want to encourage us, let doctors continue to play their role. Let them continue to play. Let's not cede it. Gradually, there's a flooding, not even an erosion, it's a flooding of people into the public health space. And if we are not careful, we may be sitting as specialists in our clinical specialty, and people who have no idea will create problems for us that we will not be able to solve. So this is an appeal to NMA to make sure that we continue and we work with the NUC, all the Nigerian University Commission, all the regulatory MDCAN, and all the other medical and dental council to make sure that people that are sneaking into the health space under the guise of this and that, we must know exactly what they are doing, especially task shift. We must not task shift to the extent that we shift everything away. So NMA must begin to look at this, what is happening in the public health space, who are the major actors now, and we must insist that doctors must develop their capacity, and make sure they take the lead. So, and I will say that while it is important to emigrate, because the Japa syndrome is there, we cannot abandon our national health system totally, because it will come back and haunt us. So, where doctors will continue to travel out, many more will travel out. Some are participating with us in this Physicians Week for the last time. Next year there will be diaspora doctors. But we must do everything possible as NMA to work with the government to see how we make sure that our house does not collapse totally. I must say that there are people who are waiting for that opportunity, and we must not allow it. So, role of NMA. NMA must continue to engage government to suggest possible solutions to improve our health system. We must continue. And it's not just about having conferences and symposium and webinars. These are good, but the policymakers are not listening. They don't attend. Even when you ask them to come and receive an award under the guise that they will listen, they will send somebody to come and pick the award. Instead, NMA must organize its expertise and commission special groups. I thank God for what our guest speaker spoke about, the years of working behind the scene. These are people that will interrogate the current challenges. We must develop a think tank. We should not just rub this problem on the head. Sit down on task think tank that will spend weeks. So how do we get innovative solutions? How do we retain doctors? The government can no longer think. We must think for them without making them look that they are not thinking. We must think for them so that we can develop a master plan, robust master on specifics, not just talk on the rhetorics. No, how do we sustain the health system? How do we finance the health system? How do we deal with this with innovative solutions? And I think we are doctors, we are the best, we are the most brilliant, and I don't believe there is any problem that defies human solution, and doctors can do that. It has been done in several countries before. After the Second World War, Japan was in tatters, but its eggheads, they sat together and they provide solution. Japan is a leading world power today. So NMA must be able to do that. And I'm also suggesting that NMA must work with other professional groups. We can't do this alone. There's NBA, there's ASU, there's ICANN, bankers, Koren, NSC. There must be a forum. If Nigeria must grow, we cannot let politicians dictate the pace and not just the pace and the direction of the nation. I want the leadership of NMA at the national, at the state level to speak with other professional groups and come up with position papers, engage this problem. We have the facts. Please, and it is important, we must go back to nation building. NMA cannot work alone, we must work with these people. Like I said, politicians have tried their best. There's a Yoruba saying that the epileptic person turns the wizard to a fool because he continues to die and wake up. So like Abiku Sologundeke, these guys managing the economy, they have completely used all the ideas they have. Now we must bring new ideas out of our toolbox. That's my plea to NMA. And finally, what do we do about diaspora? Doctors will continue to go. In fact, almost all the doctors all the students in the medical schools now, 80 to 90% of them do not ever dream of staying back in Nigeria to work. So it's a reality. But when you are faced with lemon, you make a lemonade out of it. We can't be crying. Crying will not save the situation. Complaining will not. How do we do that? So as we celebrate Physician Week in Nigeria, we must be conscious of how many of our colleagues that are not here again. They have left for various reasons that has been clearly elucidated by the earlier speaker. But this can be an advantage. Everything has its advantage. If we decide to make use of it, we can provide a platform for giving them information about what is happening at home. We can explore opportunity. Now that we are in this digital world, they can still train, they can still teach, they can even still, they can review cases, they can review slides, they can make contribution to clinical care management. And then they can set up a network for medical education. They can provide scholarship, bursary, they can help our people even when they come. They can provide mentorship, internship for our people that are traveling. People will go, but some people will stay, and some people will go and come back. We must establish a network to guide and assist others who want to go. There's nothing wrong with doctors going, but doctors must not go and become a lift attendant. No, we must work with our brothers in diaspora to make sure that when doctors go, they take up decent jobs. They are our brothers. We have an oath, Hippocratic oath, so that when they are going, those who want to go, they must have accurate information about the country they are going, about the opportunity for education. We must set up a network to assist them when immediately they are landing in those countries. The NMA in diaspora should reach out to them. Welcome to Turkey. Welcome to Australia. This is what you need to do. If you don't want to hang here, we must, because if we don't do that, many of them will travel, but many of them will not practice medicine, and they will not live to fulfill the dreams that they had when they were young. So NMA can do that. And I'm telling you, if we're able to do that, they will remember that somebody made it easier for them, and they will remember home. So we must also provide a platform for them to contribute back home in different ways without scamming them. And I put the emphasis on scamming, because people in diaspora are very suspicious of our own. When we put up a gig here, they want to be sure, is it legit? And NMA is a legitimate organization. So if individuals cannot do it, if individual colleges of medicine cannot do it, NMA can do it. We can bring them back home on leave, you know, on sabbatical to come and contribute, and they will gladly do so. And Ondo NMA can take a lead in this. So I look forward to Ondo NMA having a diaspora commission. We can even visit them, not just on behalf of Ondo NMA. See, get a database of all our doctors that have left, you know, and reach out to them. And who knows, some of the projects we are doing and we are struggling with, we are using 5 years to buy a new car. Some of these projects may be easily done if we do the right thing. So, because wherever we are all physicians, like I say, we are bound by the same oath. So, in conclusion, let me say that the struggle for supremacy between man and other organisms will continue. So outbreak, because those organisms, those pathogens, they have a right to be here too. Whether we like it or not. It's a battle between will lead to disastrous consequences, as various epidemics and pandemics have demonstrated. And this war with these pathogens cannot be won unless doctors take their commanding position and mobilize our human resources. The pathogens are smart, but we are smarter. We are smarter. We can adapt too. It's not just viruses and bacteria that can adapt. We can adapt, but we can do that successfully if we work together. Thank you very much. And I pray that doctors will unite everywhere. Happy Physicians Week.
A round of applause for Dr. Fagbemi. Thank you so much. As always, you are thorough and down to earth, giving us innovative ideas on the way to go, even way of involving the doctors in diaspora. He's talked mainly of what we should do to be prepared, even against any outbreak, going through prevention, early detection, then the management. He talked about deliberate policies to improve the socioeconomic status of the less privileged and the downtrodden that are not even seen or heard. Else, we will continue to work without having significant results if this group is not lifted. Talked about access to basic education, how it will affect health, then environmental safeguard. Then he called down on disease surveillance, talking about emergency treatment, prompt case detection, and early diagnosis and treatments. He has also talked about various actions that the government can take to make things easier and to prevent outbreak of diseases. He elaborated on collaboration and encouraged NMA to form NMA in diaspora and talked about the various advantages that NMA can derive from this. Dr. Fagbemi, we want to thank you very much for this very thorough lecture and very educative one, even within the time given to you. God bless you, sir. Another round of applause for him. Thank you very much. Now we want to take a few questions. Are there questions? I'll read out some of the comments. That was the word thought, packaged and fully delivered. Thank you. That's from Dr. Adeko Lurejo. Our past chairman, Dr. Adegbenbe, says, thank you for the beautiful presentation, Dr. Fagbemi. Thank you for your time, sir. From Dr. Ayu Olubenga. Thank you very much, Dr. Fagbemi. Please kindly post your questions so that we can take them, if there are any. We will note them. Now we will proceed to the next lecture, which is to be taken by our own dear Dr. Ndidi Okonoga, the passionate radio-oncologist, who, if left to her alone, there will be no breast cancer or any cancer in any woman in those states. Yes, okay. With the amount of work that she's doing. We are glad to have you. Thank you very much. So you'll be taking us on the prevention and issues around breast cancer. More so, this is Cancer Month, and a lot of cancer awareness for prevention is going on. We're happy to have you, Ma. Thank you very much. Now the citation of Dr. Ndidi Okonoga, just a very brief one. She is a consultant radiation and clinical oncologist at the University of Medical Sciences Teaching Hospital, Akure in Ondo State, and also a senior lecturer at University of Medical Sciences, Ondo State. She was born in Lagos and had her primary education and secondary education in Lagos. She had a degree in medicine and surgery at the College of Medicine, University of Lagos. Thereafter, her service and internship at the same institution. NYC was in Lagos, and then she proceeded to Lagos University Teaching Hospital for her postgraduate residency training in radiation and oncology. Her field of interest is in breast cancer, cervical cancer, and prostate cancer. She has many research works related to this field, and she has a special interest in palliative care, research, and current trends in the management of breast, cervical, and prostate cancer. She is a member of many associations and organizations, including but not limited to Cancer Education and Advocacy Foundation in Nigeria, Breast Cancer Association Nigeria, Association of Radiation and Clinical Oncologists in Nigeria, Medical Women Association of Nigeria Ondo State chapter. She has been deeply involved in creating awareness of cancer and its early detection. She has the passion to empower youth, women, and men in the knowledge of early diagnosis of cancer. She's actively organizing programs in collaboration with many other professional bodies, not just limited to medical, to help reduce the burden amongst people living with cancer and to improve the quality of care in those with cancer in the society. She's a facilitator and speaker at various international and local conferences and seminars. She's a prolific writer and author of several books, one of which is Overcoming the Fear of Chemotherapy. She is currently the head of training at the University of Medical Science Teaching Hospital, Akure, and the Deputy Director of the Institute of Advanced Clinical Studies at the University of Medical Science, Ondo State. Her hobbies are reading Good afternoon, everyone. So sorry, there's a mild technical itch due to network, but we are sorting it out. We'll be with you in a short while. I hope you can all hear me while we wait for the mainstream network to come on. Can we all hear me? Can you hear me, sirs and mans? Thank you very much. So, yes, so I said early detection and current trends in the management of breast cancer. Now, by way of introduction, there are various health conditions that we know affect men, women, and children. And one of these health issues is cancer. And it is the uncontrolled and abnormal division of cells in the body. We all know these basics. And we know that cancer is a non-communicable disease. It can occur in any part of the body, except the hair, the teeth, the fingernails, the cornea, and even the heart. The commonest cancers we know that occur in women is breast and cervical cancer. And we know that for men, it is prostate cancer. And early detection of breast cancer increases the chances for successful treatment. I quickly put up the anatomy of the picture of the breast, and we know the basic anatomy is a modified sweat gland. It is located on the anterior chest wall, and its size varies for every individual, but it's usually rudimentary in men. And the function of the breast is for cosmetic purpose and also for nourishment in infants. Quickly, we look at the arterial supply, the venous supply, and the lymphatic drainage of the breast. We know that the main supply is from the subclavian artery and its various branches, the thoracoacromial and the axillary artery. Also the venous drainage and the lymph. And this is very, very important, especially when it comes to the management, surgical management of breast cancer. Now, quickly, breast cancer is an abnormal and irregular proliferation of cells in the breast. It is the commonest cancer found among women all over the world, including Nigeria. And the peak age is 45 years, but can occur in any age group. Sadly enough, the age is really coming down. And practice-wise, the youngest patients I've managed now was an 18-year-old. But unfortunately, I could not even commence my treatment because she died of tetanus following scarification marks given to her by the herbal practitioners. So the age is really, really coming down. I see more of women in their 20s and in their 30s. And the risk of a woman developing breast cancer increases with age, but we realize that the risk is really coming down. And it is the leading cause of cancer death among women all over the world. It accounts for 1% when we're talking about the male breast cancer. We realize that breast cancer also occurs in men, but it's not as common as it is in women. And the peak age is usually 10 years older than that of the females. And the peak age in Nigeria is 50 to 59 years. And the treatment is same as we do for women. Looking at the epidemiology and the occurrence of breast cancer, we realize that it's still the commonest. If you put in all the cancers that can occur in a woman, breast cancer still accounts for 26% of cases. Now, 1 in every 8 women will develop breast cancer in their lifetime. In Africa, breast cancer is responsible for 1 in every 4 diagnosed cancer and 1 in every 5 cancer deaths in women. Breast cancer is currently a major scourge among women in Nigeria, and WHO has estimated that in Nigeria, about 2.26 million cases were recorded in 2020, and it is the 5th leading cause of deaths worldwide. And Nigeria has the highest number of deaths from breast cancer in Africa. And there is increasing incidence daily of breast cancer in Nigeria, and Ondo State is not exempted. Now, what are the risk factors for breast cancer? We don't know the cause of breast cancer for now, but we realize that there are risk factors that are associated with breast cancer. And the first one is age. Like I said earlier, as a woman gets older, the risk increases. Then gender, it is more common in women than in men. Early menarche, late menopause. The longer years a woman menstruates, the higher the risk
of developing breast cancer. Family history. Breast cancer runs in families, we know that, especially first-degree relative. Once there is a history of breast cancer in a first-degree relative, there's a very high chance that such an individual, when they get older, they will have the disease. Then diets, high fatty diet, high cholesterol diet, high red meat intake. We realize that these things may predispose a woman to developing breast cancer. Excessive alcohol intake, tobacco smoking, nulliparity. You know, women that have not used their egg and the hormones just want to look for something to do. Such a woman may develop breast cancer later in life. And then obesity, of course. A woman that is obese has a very high risk of developing breast cancer. I try to group the risk factors into modifiable and non-modifiable risk factors. When we say non-modifiable, these are factors that you cannot change. Okay, and so we have race, we have family history, genetic factors, and menstrual history. For the modifiable risk factors, we are looking at diet, obesity, breastfeeding, alcohol and tobacco intake, and even hormone replacement therapy. Now, still talking about the risk factors, I just put there canned foods. Excessive intake of canned foods may predispose to developing cancer, especially breast cancer. Now, early detection of breast cancer and diagnosis. There's something we call triple assessment. And what we are trying to say is that we have breast self-examination. A woman must know how to examine her breast. We have clinical breast examination, where a doctor must, where the doctor should examine the woman at least once in 6 months or once in a year. Then mammography. Any woman above 40 years must go for mammogram check once, at least once a year. And women younger than 40 years should go for ultrasound scan. These are just ways of screening, you know, to prevent or to detect the disease early enough. Other tests are FNAC, which is fine needle aspiration cytology, or excisional biopsy, chest X-ray, bone scan, CT scan, and even immunohistochemistry. We do this so that we are able to know the subtype of breast cancer we are really dealing with. Now, talking about genetic testing, because one of the ways to diagnose also during diagnosis of breast cancer, once an individual has a strong family history of breast cancer, or early onset of breast cancer, or high risk factors for breast cancer, such an individual should go for breast cancer gene 1 and 2 testing. And we'll take either the blood or the saliva for sampling. And genetic counseling and result interpretation is very, very vital. And so if the test comes back positive, that means the individual has mutation found. And if negative, no mutation was found. A positive result may lead to increased screening and prevention or reducing possible modifiable risk factors. And so other genes that are associated with breast cancer include CHEK2, ATM, and RAD50. What are the signs and symptoms of breast cancer? Most of us know this. Usually they present with painless, usually painless, but they can be painful breast lump, ulcer on the breast, nipple retraction, bloody nipple discharge, skin rash around the nipple area. And by the time it's now metastatic, they come with swelling of the arm, jaundice, headache, chest pain, convulsion, and even they come in coma. And just a summary of the signs and symptoms can present with lump, discharge or bleeding, change in size or contour of the breast, nipple retraction, change in color or appearance, and then redness or change in skin color. Now, I just put up pictures of how the breast lump looks like. You can see it's an abnormal swelling in the breast. So it can be as small as an orange seed or as big as an orange. And then the breast can also be hard, and then skin changes can present with nipple retraction. The nipple goes in and doesn't come out again. They can have peau d'orange. Peau d'orange is appearance like an orange. And most times, more than 75% of our women come in this stage. And when a woman comes like this, it's already a locally advanced disease. And by the time you investigate further, most of them are already metastatic. And then they can have auto amputation where the breast eats up itself. And like I said, this is when most of these women come to us. They can have breast ulcer, or it can even go to the bones and cause pathological fracture. And so a little trauma will just, cause fracture to the bones. And quickly, the staging, we have the TNM staging and we have the Manchester staging. But I just summarize the staging in this picture. We have stage 0, which is carcinoma in situ. At this stage, the cancer has not breached the basement membrane and is very, very, good to treat breast cancer at this stage. In fact, more than 95 to 100% chances of cure for stage 0. Then we have stage 1, stage 2, stage 3, and stage 4. Stage 4 is when the disease has gone beyond the primary site. Quickly, let's look at current trends in the treatment of breast cancer. For breast cancer, we have surgery, chemotherapy, targeted therapy, hormonal therapy, and even radiation therapy. Now, when it comes to the management of breast cancer, it is usually based on the stage of the disease, the nodal status, the pathological characteristics of this tumor, the grade, and the immunohistochemistry type, the hormone receptor status, the age of the patient, the presence of comorbidities, whether they are hypertensive or diabetic, patient's preference and values. Some will tell you they don't want surgery, some will tell you, it depends. And then current clinical guidelines. We have different guidelines we use when it comes to the management of breast cancer. Now, the treatment options could be local therapy or systemic therapy. When we talk about local therapy, we are looking at surgery and radiotherapy. And if it is systemic therapy, we talk about chemotherapy, hormonal therapy, or targeted therapy. Quickly, that's just a picture showing the lumpectomy, and then the second picture just showed one of my patients that had bilateral mastectomy. So some of these women opt for bilateral mastectomy. Now, we can also have mastectomy in men. Like I said earlier, men also have breast cancer. I have managed up to 10 men with breast cancer. And so some of them have mastectomy also if they come late or they come in the early stage rather. But we realize that the men even come in the later stages because they won't even think it's breast cancer. They might just think it's just an ulcer. And by the time they are coming to us and we go further to check, it's usually breast cancer. Now, mastectomy. We have total or simple mastectomy, which is the removal of the breast without nodal dissection. We have what we call modified radical mastectomy, which is removal of the breast with axillary lymph node dissection. There is extended radical mastectomy, where we remove the breast parenchyma and the muscles, which is the pectoralis major, and axillary lymph node dissection. And then we also have skin sparing mastectomy. That's when we are trying to look at immediate reconstruction following the surgery. I just put up this picture to show us that we have different prostheses. So when these women have this mastectomy, we offer them this prosthesis. And then breast conservative surgery is just to maximize disease control and improve quality of life in early stages of the disease. And it demands clear histological margin with a rim of normal breast tissue around the primary tumor. And it could either be lumpectomy or chondroitectomy. But my general surgeons online will agree with me that we rarely do this here. Though we do it in Nigeria, but we realize that most of our patients come in the advanced stages of the disease. And what are the contraindications to breast conservative surgery? We have the absolute and we have the relative contraindications. For the absolute, multicentric disease, persistent positive margins, and then lack of patient's consent. Then for the relative contraindications, you can have recurrence in previously conserved breast or not able to achieve an acceptable cosmetic outcome. Chemotherapy. Chemotherapy, this is the use of cytotoxic drugs, to destroy cancer cells. And I said it is more of a systemic therapy. And there are so many classes of chemotherapy. And the combination of drugs depends on the stage of the disease and the histological type. And it can be given as neoadjuvant or adjuvant therapy. And also it could be of curative intent or palliative intent. Quickly, hormonal therapy. Hormonal therapy slows or stops the growth of hormone-sensitive breast cancers. And it acts by blocking the body's ability to produce hormones or interfere with the effect of hormones on breast cancer cells. So it could be given before surgery or after surgery, chemotherapy or radiotherapy. And there are different types of hormonal therapy. And it can be for a premenopausal woman or a menopausal patient. So we have tamoxifen, letrozole, or even the goserelin. Now, the radiotherapy is a local therapy when it comes to management of breast cancer, and it is the use of ionizing radiation. Examples are electron, photons, gamma rays, and so on to treat cancer. And it is used after lumpectomy or after a mastectomy has been done. And most times we even use it for advanced stage of the disease, where these women come with fungating, bleeding breast masses. So we can give radiotherapy to stop the bleeding, and we call it hemostatic dose. And then the treatment can last for 3 to 4 weeks. And we have 2 types. We have the teletherapy and we have the brachytherapy. And this is just how the teletherapy machine looks like, called a linear accelerator. And then as radiation oncologists, we mark the women up and we plan them before we put them under the machine for the radiotherapy. And that's the marking there. We mark the chest wall and the anatomical positions or site that we look at. And then we mark the supraclavicular region and also the axillary area. Now, brachytherapy is the use of radioactive sources placed within site of the tumor. And we do this for breast cancer also, especially for stage 0 and stage 1. And we give a large dose over a short period of time. And this is just done so that we are able to protect the surrounding structures. And it is used for early stage, like I said. And the sources we use are iridium-192, palladium-103, or iodine-125. We even use gold seeds, radioactive gold. We also use it in the management of breast cancer. And then it can be as a single therapy, or we give it as a boost therapy in addition to teletherapy. And these are just the machines for brachytherapy. And this is how the procedure is done. Most times it is done under general anesthesia, where we position the breast, we apply our calipers, and then we pass the catheter through the calipers. Once the catheter is in place, and we do this through CT guide or MRI guide, and then once the calipers are in place, we now connect it to this machine that I showed earlier, this high-dose brachytherapy machine. It depends on the source we are using. And then once the source is on, and then we treat. And like I said, we do high-dose rate treatments now, where we give as high as 14 gray per hour. And so within few minutes, we treat the woman. But the other aspect is that we can leave the radioactive source, within the breast. That's when we are using gold seeds. Why? Because we usually use sources that have lower half-lives, so that within few days, the radioactive decay will be faster. Now, advancements in radiotherapy, we have different volumes, chest wall, whole breast, partial breast, or even intra-op radiotherapy. And we now have advancements in the planning of radiotherapy, where we now use modulated arc therapy, inspiratory gated radiotherapy, or even intra-op radiotherapy, targeted therapy, and immunotherapy. This is quite modern now, and we are using it now in Nigeria. I even use it now in my clinics. And these are drugs that act by targeting the different cancer cells and also go through the process of immunotherapy, where the immune system also recognizes and attacks the cancer cells. And it can be given before or after surgery. And it's very, very effective in metastatic disease state. And so women with stage 4 now have better and good quality of life, though they are very, very expensive. Examples are trastuzumab and pertuzumab. The future for breast cancer management, clinical trials are ongoing, and we have what we call CAR T cell therapy. This is when we use immunotherapy, for HER2 positive breast cancer patients. that have metastasis to the brain, they now have better quality of life. We also have new therapeutic options in neoadjuvant therapy, where we offer hormonal therapy and targeted therapy together. We also have ongoing studies on ways to enhance breast cancer screening using technological advancements in imaging. And there is a very popular one now, which is the 3D mammogram, which is also called tomosynthesis. In conclusion, early detection is the key, and there are modifiable and non-modifiable risk factors for breast cancer. Standard diagnosis and treatment improves quality of life and survival. The improvements in breast cancer diagnosis and current trends in treatment will provide better outcomes and quality research opportunities. Like I always say, early detection is the key, and I believe together as NMA, we'll fight cancer together. These are my references. Thank you very much.
Thank you very much, Dr. Okonuga. Another round of applause for her. Dr. Okonuga, thank you for honoring us once again and doing what you do best, campaigning and raising awareness against cancer so there can be better outcome. I want to say that there is very little to talk about or to add, because Dr. Okonuga has taken us through breast cancer, how common, the risk factors, and the methods of treatment. She has equally stressed the issue of technological advancement in the treatment, making outcome better in people with breast cancer. Dr. Okonuga, we are very grateful. Thank you very much. Now we'll take questions and comments. Now, I have a question for Dr. Okonuga. My question is that this gene testing, is it available in Nigeria? Because people with strong family history or strong risk factors may want to utilize the opportunity for early detection. Thank you.
Thank you very much for the question. Yes, genetic testing is readily available in Nigeria, especially I think in places like Lagos and Abuja. But the challenge there is that aside being expensive, most of the genes that we try to test, because I just put up to the BRCA1 and BRCA2, that's breast cancer gene 1 and breast cancer gene 2. There are other genes that we also test to know whether an individual has a positive genetic testing or negative. So because of this challenge, most times we're just able to screen for BRCA1 and BRCA2. But like I said, there are other genes that can be tested. So yes, it's available in Lagos and I think Abuja also.
Thank you very much. Thank you very much, Dr. Okonuga. I will read some of the comments that I have for you here. Thank you, Dr. Okonuga, for the passionate presentation from our past chairman, Dr. Stella Adebenge. Samuel Ibitoye says, thank you, Dr. Okonuga, ma, for your presentation. From Dr. Belela, God bless you, ma. You are doing excellently well. The state appreciates your great job, ma. Thank you very much. Please, kindly drop your email address if you want us to send the presentation to you, the slides. Thank you very much. At this point, if there are no questions, I can't see any hands up. On behalf of my chairman, Dr. Ebe Olumuyiwa Alonge,